Hi, this is Brandon Knight. I'm a transition year resident at St. Agnes Medical Center, and today I'm going to be talking about postpartum psychosis, its symptoms, diagnosis, treatment, um, as well as etiology, epidemiology, and also its the safety of treatment during breastfeeding. I've, our family has known someone who dealt with this, so this was an especially interesting topic for me. And also, of course, I um, find the whole subject of drug level transmission from maternal to fetal drug levels interesting and important, as I can see the fear that would be there for certain treatments for the mother. So explaining and knowing those are very important, I think. So, yep, so I'll be presenting on postpartum psychosis today. So postpartum psychosis, it's not recognized by DSM-5, but by many clinicians. It's recognized, and kind of a agreed upon definition is that it's a psychotic disorder which may present in women during postpartum period, generally within 2 to 4 weeks of birth, depending on what source you're looking at. In addition, um, different physicians, psychiatrists have argued that it also includes cognitive impairment or disorganized thinking, and may include mood disorders as well. Though there's no fully agreed upon definition, but many physicians have that view. It was included historically in the 50s and 60s in DSM-1 and 2, but later in 1980 it was removed from the DSM-3. So now really most of the psychosis symptoms would be psychotic disorder or mood disorder with psychotic features, would be some of the diagnoses would fall under now. And one of the big, of course, publicized problems or pathologies that causes this to be so important and viewed with concern is that there's a relatively high risk of suicidal ideation and action, as well as homicidal ideation and action focused around the newly born infant. So it's considered a psychiatric emergency. So the etiology of postpartum psychosis is unclear. It's likely a combination of biophysical factors, hormonal changes in the postpartum period, psychiatric history, especially as detailed below, and social support slash expectations during the postpartum period. And also some studies have looked at potential chemical signaling related to 5-HT and other serotonin-related receptors. Some of the risks for postpartum psychosis, a personal history by the patient of postpartum psychosis, history of schizophrenia or schizoaffective disorder of psychotic disorders in the patient or family, personal or family history of bipolar disorder, which is a very strong correlation. I think it's somewhere in the realm of 70% of patients who have postpartum psychosis are found to have a history or will develop bipolar disorder. A risk is first birth, primiparity, and it appears to be not even related to the fact that patients with postpartum psychosis go on to often not have any other pregnancies. It appears to be an independent risk factor. If this is a patient's first birth, might be related to psychosocial stressors of first birth versus biologic factors. It's unclear at this time. Another risk is discontinuation of psychiatric medications during pregnancy especially, bipolar if the patient's bipolar, or and also schizophrenic, and they've stopped their medications during pregnancy. Another risk factor is sleep loss. Similar, because often the bipolar relation, so bipolar, sleep loss, all kind of interconnected. And then final risk, another risk is history of negative pregnancy or birth outcomes, things like preterm births, miscarriages, etc. Kind of large stressors or negative occurrences in the past with birth. Epidemiology rates vary, but one study showed 0.089 to 2.6 per 1,000 births. Other studies have shown point, you know, 0.6 to 0.08, or others have shown one realm of 1 to 3 per 1,000 births. So it varies, but in that range. And then, of course, the concern is that the rate of infanticide by mothers with postpartum psychosis is approximately 4%. So small percent of a small percent, but high harm outcome. So symptoms of postpartum psychosis. As I noted before, despite being called postpartum psychosis, there's quite a bit of belief that it includes, the definition or disease includes not only psychosis, but also mood disorders or almost delirium-like symptoms. So the symptoms of postpartum psychosis are usually rapid at onset, may occur within hours or a day, and they occur within the first few weeks postpartum, 2 to 4 weeks sometimes within that or earlier time frame. Early symptoms of postpartum psychosis may appear similar to postpartum blues. There's mood fluctuations, insomnia. Blues kind of has anxiety. Psychosis might have more irritability, but the main difference being that postpartum blues generally resolves within a few days, whereas postpartum psychosis will worsen from these symptoms, as well as occur for a longer period generally. The later developing symptoms of postpartum psychosis, some of them, things like confusion, disorientation, may appear similar to delirium, but there's also other signs often, including things like derealization or depersonalization, disorganized behavior, these things being some of the psychotic symptoms like disorganized behavior, visual hallucinations, generally over auditory, delusions. Often the delusions are related to themes of the newly born child. Suicidal ideation or homicidal ideation directed at the newborn may be present, and catatonia may also be present. For symptom rates of postpartum psychosis, a cohort study of symptoms in patients admitted to mother-baby inpatient unit with postpartum psychosis found certain rates of symptoms. They found a high rate of things like irritability, abnormal thought content, and anxiety, being 73, 72, 71%. Disorganized thinking or behavior, disorientation, and disturbed consciousness being lower in frequency among these patients, 25%, 20%, 10%. And catatonia, suicidal ideation, and homicidal, infanticidal ideation being 5%, 19%, and 8% respectively. So not necessarily being as common, the infanticide or suicidal ideation, not being as common as many of the other symptoms, but still, of course, very high risk of harm to the patient herself. Making correct diagnosis very important. So some of the possible presentations of postpartum psychosis. That same study above also divided the patients into their mood disorders that were occurring at the time, if they had mood disorders, and also more delirium / psychosis type. So they had depression, anxiety predominant, manic predominant, or disoriented / disturbed consciousness predominant. They found 34% of patients were manic predominant postpartum psychosis, 41% were depression predominant, and 25% were disoriented / disturbed consciousness predominant. And it just illustrates the fact that there often appear to be mood disorders that occur along with the psychotic symptoms in postpartum. So the clinical course of postpartum psychosis, the above study previously mentioned showed postpartum psychosis having a duration of 1 to 2.5 months, depending on if the patient was manic or depressive predominant, respectively, for the acute episode of postpartum psychosis. And women who experience postpartum psychosis, while they may recover within that time frame, they do have a significantly higher risk of developing another severe psychiatric episode. It can be up to a 50 to 80% chance. And this episode is usually bipolar disorder, other studies have shown. So history and evaluation of patients with suspected postpartum psychosis. Of course, initially there should be a thorough neuropsychiatric history and physical taken. And some important points to remember when taking this history, along with the thorough history itself, remembering to ask about medical history to rule out any medical causes of the patient's symptoms, asking about obstetric history, negative birth or pregnancy outcomes or occurrences in prior pregnancies or in the current pregnancy, substance use or abuse as possible cause of symptoms, psychiatric medication history, whether the patient takes any, and their adherence during the current pregnancy, as many mothers or future mothers may change or stop their psychiatric medication regimen due to fear of the medication's effects on the child. Asking the patient about their social support at home and caretaking roles of family and support network to try to discern the amount of stress or strain being placed on the patient at home. Asking about any recent major stressors or traumas in the patient's life, and asking directly about suicidal ideation or homicidal ideation, including towards the infant, in a non-judgmental manner, being sure to ask it, as many or some mothers may have thoughts of hurting themselves or their baby during pregnancy. Has that occurred with you during this pregnancy? Judgmental manner. Diagnosis, in addition to history, well, really all patients should, postnatal, perinatal, should undergo depression screening. So things like mood disorder questionnaire or the pregnancy depression screening. So those should be available at the time or should be completed by the patient at the time. And then also mood disorder diagnosis via interview or questionnaire can help with the diagnosis in addition to the history and psychotic symptoms or other symptoms as described before. So some possible lab and imaging evaluations that can be performed in patients with suspected postpartum psychosis to rule out other causes, organic or any other cause. Can include a CBC, complete blood count, to look for things like infections or anemia, which may be causing symptoms. A complete metabolic panel to look at, make sure the patient doesn't have electrolyte derangements, any glycemic abnormalities or hepatic abnormalities. Looking for vitamin deficiencies by testing things like B12 levels, folate levels, and thiamine levels. Thyroid function tests, looking for hyper or hypothyroid causes of symptoms, as well as anti-thyroid peroxidase antibodies. Graves' disease may occur in up to 19% of women with first-time postpartum psychosis. So getting those anti-TPO antibodies can help rule that out as a cause symptoms. Urinalysis to look for UTI or any renal disease might be causing symptoms. UDS, looking for substance use or abuse disorder. And yeah, of course, cultures if the patient has a fever, looking for infection. And CT, MRI brain may be performed in patients if they have neurologic findings, though it isn't considered routine, or it shouldn't be undertaken if the patient just is suspected of postpartum psychosis, but only if they have neurologic findings on exam. So treatment of postpartum psychosis, there's the immediate and the more long-term treatment. Immediate treatment is focused on treating the immediate symptoms and removing risks of harm of the patient to themselves or to the child. It's recognized as a psychiatric emergency, so inpatient psychiatric hospitalization is required for diagnostic workup and treatment of the mother and child. And as far as pharmacologic treatment, lithium is considered really a mainstay of treatment. It can be either a monotherapy or given with an antipsychotic. Lithium does require frequent level measurements for appropriate dose level adjustments during the postpartum period due to the mother's changing physiology, biophysiology. And then for immediate treatment of the mother as well, consider adding short-term benzodiazepines for short-term, as in short, for not for long periods, for agitation and insomnia. Don't want to give long-term benzodiazepines due to fear of complications with the infant, but short-term they can be useful in agitation, and then also insomnia, as sleep loss is considered a risk for postpartum psychosis. And of course, if all else fails, as with severe psychosis or depression, we can similarly treat postpartum psychosis with ECT if they don't respond to medications, or if they need rapid treatment due to high risk to themselves or child, things like SIHI towards the child, catatonia, poor oral intake, and severe agitation. So lithium safety in breastfeeding. Lithium is excreted into the breast milk in concentrations, both in the breast milk and in infant serum. They're highly variable. According to Lacted, most sources don't generally see lithium as absolutely contraindicated during breastfeeding, especially if infant is over 2 months old, though some drug lists state that lithium is contraindicated. There are many reports of infants who successfully were breastfed during maternal lithium therapy without any adverse effects. Lithium may have heightened risk of adverse effects on breastfed infants when the infant has poor elimination of the drug, for instance, infant dehydration, or if the infant's premature. Maternal lithium levels should be closely monitored and dose adjusted postpartum if she chooses to breastfeed, as lithium levels vary significantly in the postpartum period. Infant serum lithium levels, as well as infant renal and thyroid levels, should be monitored if a patient is placed on lithium and she continues to breastfeed. And in addition, a neonatologist or pediatrician should be consulted if the patient continues to breastfeed while taking lithium. Antipsychotic safety in breastfeeding. And during breastfeeding, second generation antipsychotics, except clozapine, are all considered relatively safe. It's estimated that less than 5% of second generation antipsychotics are received to the infant through breast milk. Olanzapine has the most data regarding its safety during breastfeeding and is considered safe during breastfeeding. Large studies of olanzapine, or a large study of olanzapine from 2013, showed that 15.6% of infants exposed to olanzapine in breast milk had adverse events, but that these events were generally tolerable, the most common being somnolence in 4% of infants, irritability in 2%, and tremors in 2%. Other studies have shown no infant side effects of antipsychotics use in mother during breastfeeding. Maternal doses of olanzapine up to 20 milligrams daily, according to Lactamed, produce low levels in milk and undetectable levels in infant serum. Quetiapine also has data supporting its general safety, but olanzapine should be first tried due to its more extensive safety data. So in addition to these treatments, pharmacologically, it's also a consideration to bring up to the patient not to breastfeed in postpartum psychosis, of course, due to the possible contraindications or adverse effects on the infant of lithium and antipsychotics on breast milk, but also due to the risk of sleep deprivation, which is a risk factor for postpartum psychosis. And in addition, once a patient post-acute is out of the inpatient setting, there should be follow-up with things like psychoeducation of the patient and the patient's family on the diagnosis of postpartum psychosis. Therapy should be recommended, things like cognitive behavioral therapy, mother-infant therapy if available, etc., couples therapy, peer support, and also supporting the partner, of course, either support groups or working with family, extended family, finding help to help the partner properly support and be able to deal with the patient's challenging diagnosis at this time. So here to summarize the treatment, I just wanted to share this flow chart that shows kind of the treatment. At the top, it just talks about preparing, looking at patient's history, mitigating risk if they have a history of postpartum psychosis or psychiatric history that they may relapse on or maybe stopping medications for in preparation to try to help prevent postpartum psychosis, as well as things like mitigating stress and things like that. And then the middle portion just talks about when the patient has postpartum psychosis, has been diagnosed with it, looking at their medication history is the main thing. Seeing if they've had bipolar, have they continued or have they stopped their bipolar medication, what's worked in the past, restarted if it's worked in the past. If they had postpartum psychosis before, also restart that medication. And then once they've been diagnosed and you've gotten a little history, then generally admitting the patient and beginning either their old bipolar or psychiatric medications, or beginning just a antipsychotic like olanzapine, and you can also use lithium. Both together seem to work very well. Benzodiazepine short term for sleep and things like that, considering breastfeeding, and then ECT, and then post-acute care of therapy and education and familial support. So prevention of postpartum psychosis, it can be divided into screening for postpartum psychosis, or early identification of it and people who are at higher risk, controlling patients' psychiatric conditions during pregnancy, and then prophylaxis after pregnancy and postpartum period. So screening, one method is major depression questionnaire to screen for depression. All postpartum patients should be screened for depression anyway. So it's a good screening tool to use to look for depression. And of course, patients may have depressive symptoms who have postpartum psychosis. And it should also be recognized again that the depression found in this screen might be unipolar, but it could also be bipolar, in which case there'd be a high correlation, or if the patient has postpartum psychosis. So checking for that screening, identifying and offering support before and during pregnancy to women who are at higher risk of postpartum psychosis preventatively, continuing psychiatric or bipolar, including bipolar medications during pregnancy, of course, depending on risk-benefit analysis as agreed on by physician and patient. Though, of course, Ebstein's anomaly often won't continue lithium during pregnancy, but if there's other antipsychotics, for instance, continuing those. And then in the postpartum period, you can use both lithium and antipsychotics prophylactically if a patient has a history of postpartum psychosis. Lithium can be used prophylactically for postpartum psychosis in addition to bipolar treatment. And if it was stopped for concern of congenital anomalies like Ebstein's, it should be restarted if the patient was on lithium before. And then also antipsychotics can be used prophylactically, though there isn't much data regarding this. One small study has shown olanzapine may decrease risk of postpartum psychosis. So summary, postpartum psychosis includes symptoms both of psychosis, mood disturbance, and confusion or delirium-like symptoms. It's a condition that occurs in postpartum mothers in up to 3 out of 1,000 live births. so 0.3% of live births. Risks include bipolar disorder, schizophrenia, poor sleep, and negative occurrences during birth or birth history. Acute treatment of postpartum psychosis involves inpatient admission, lithium, with or without antipsychotics, with possible discontinuation of breastfeeding due to possible effects of especially lithium in breast milk to the infant. Also, treatment may include possibly benzodiazepines and ECT. And prevention of postpartum psychosis includes screening for mood disorders in the postpartum period, closely monitoring patients with a history of postpartum psychosis, and pharmacologic prophylaxis in the postpartum period. And these are my resources for the presentation. Thank you for listening. Hope you have a good day.